for iCCA, which is a bit of a rare disease and a rare event, but we will go through. So first and most important, there is a new season of transplant oncology. And we transplant every organ in the world, almost, but the only one who's used for oncologic purposes more and more is the liver. And we have to ask ourselves if something is wrong with us surgeons. We'll see how and why. And indeed, the transplantanology, it is very selective. If you want to do transplantation for malignancies, the number of patients you need to see is immense, about one transplant for about 50 to 100 patients you screen for colorectal cancer. So in transplant oncology, the tumor is preferably primary, if secondary it should be controllable. Disease must be intrahepatic only and responsive to treatment. And of course, the unresectability is a big word, we'll go through that. Is iCCA fit for this exercise? First, let's look what is iCCA. Cholangiocarcinoma is a bright spectrum from the radicals of the biliary most distant liver portion into the ampulla. For transplantation, of course, we speak about perihilar, not the topic of today, and the intrahepatic. The truth is that not only from the anatomical, but also from the behavior, Mr. iCCA, we don't know if it's always the same. In India, you have many people with the same name, and they have probably 100,000 Mr. Guptas, but they have different addresses, they have different persons, and they have different telephone numbers. iCCA is exactly like that. iCCA is a disease with many phases, and that is why we have observed some fantastic results and some total catastrophes. Unfortunately, most of the time that is the case. We try to get closer to it and to get classification, the famous mass forming, periductal infiltrating, and intraductal. And this is a very gross way of going. We will see that there is a bit of science coming to help us. Further, we know that 50% of tumors are of the mass forming, that's the usual that we are used. However, the periductal infiltrator, rare and pretty dismal, and the mixed form or the intraductal are also common. Now, cholangiocarcinoma is a disease that is relatively rare. It is more prominent in parts of Europe. I tried to look at India. In India, there is some difficulty with the registries. In northern India, you have a sky-high incidence of 21.5 per 100,000, and there is in the literature some evidence from Kerala, exactly your place, where beautiful Kerala is, where an increasing incidence, the numbers are around 10, 15, but it's not really clear. The mortality, we see here, is quite high, differs in different parts of the world, with UK and Europe most. I am afraid that much is depending also on the quality of the registries and also on the advancement of the healthcare systems with diagnostics that are appropriate. Now, transplantation for liver tumors is not a new thing. As a matter of fact, it is the start of transplantation. I show you here Starzl, and the second gentleman is Fischelmeier, the third is Rudi from Wien, a pioneer in colorectal. But I wish to break a word from Rudi Fischelmeier, who was really obsessed with transplantation for malignancy. He is the boss of my old boss, and I come from that school. And the beginning was a technical success and a total disaster, clinically with recurrences. Now we see a new era. We will look into that. And this is a slide from Starzl. The third transplant was done for bowel cancer. These are slides from Mr. Kahn. These are original slides, digitalized. The death occurred for tumors are extremely high, up to 14 out of 62. And here, the transplantation from Bischelmeyer, 47 patients, 2 more patients. You see the survival is absolutely pitiful. The patient survived the operation, but not the disease. If we look further in the past, in the beginning, the results are quite poor. And I put the red line, we will see it all the way, as a 50% survival at long term, as a way to look to the problem. In this series, there were 13 for peripheral cholangiocarcinoma, so it was a disease that was used. And now I say, errar humanum est perseverare auto diabolicum. To err is human, but to persist in the error is diabolical. And so we see that the results were terrible, and we continue to do these transplantations. And it seems that this is something, obviously, you know, it became very famous now with the new Pope, because he's from the Augustinian order, and this is what he said rather than Seneca. Now, in 2014, these were the guidelines from Europe. The guidelines for intrahepatic cholangiocarcinoma. You see very nice, you see the horrible gemcitabine here, but there is no transplantation. There is a reason, maybe. And here, the guidelines, always from ESA, published in July 23, from ESA, where indeed you see consider transplantation for single lesions, and we will look into this. So nowadays we start thinking again about this disease with liver transplantation. Now, of course, liver transplantation, you have liver resection and liver transplantation. I believe that if we look into liver resection, and we will now, we will learn something for transplantation. And I will start very, very far away. It's almost prehistory. This is our series from when I was in Germany, 1998-2006. 8 years of work, 340 patients with cholangiocarcinoma. You can see that intrahepatic cholangiocarcinoma was almost as much as higher. We had a lot of experience. But look into the series, 142 patients and 70 resections. And further, at the time, poor knowledge, not as good imaging. Almost half of them were negative laparotomies. Today would not be excusable. However, we did operate 70 patients, and of these, you see massive liver surgery, right trachectomectomy, left trachectomectomy, 2/3 or more of the cases, and multipleurisegmentectomy, even repeated hepatectomies in the series. The results. The results, 50%. This is all cases that I show you. It's 48%. And if we do the extended resection, thinking of having more resection, more tissue, wrong of course, and more radicality, only 52%, so 4% more than before. Please remember this picture, 50% with massive resections, because this is a kind of a regimen and a level that we need at least to reach for transplantation. Now again, to the guidelines, no transplantation and resection in several series has shown that the recurrence pattern is high, of course, and the resection again at maximum in 50%. We see no lymph nodes and the size less than 6, so we start getting some criteria. Here, from the very, very big series from France, the margin, the more the margin, the worse the result. More than 1 centimeter needed, and if the more you become down, if you have a 2-4 centimeter, you cannot make it. If you remember the lecture of yesterday of Guido Torsini, my friend, this is not the type of surgery, same type of surgery, different disease, we need to apply different rules. Of course, R0 is needed. And further, in a large series from the United States, perineural invasion, and satellite lesions, very, very important satellite lesions, because there are satellite lesions in this disease, and that's the reason why you need more radicality. Again, barely 50% at 6 years in the best cases. In this series, it looks like a telephone book, but you can notice that there is none reaching 50% at 5 years. And further, if we look at the resection, the staging size, the famous size by Massimo, the Milano criteria, more or less than 5 centimeters, it counts. And we will see that nowadays we know a bit more, but size, it is important. As you see, the resection we did were huge trisectionectomies, because this disease usually presents already as very large tumors or multiple tumors. Again, to err is human, but to persist is diabolical. We continued with the resection, and we used to employ ALPS for advanced cholangiocarcinoma. It is like, you know, if you have to rescue somebody, but they don't come into your mattress and they just die on the ground, jumping down from the window. And in this surgery, it's easy to propose futile procedures and to look a fool with yourself, a fool with your patients, and a fool with the surgical community. This is the fool of a brilliant painter from Brussels in the Middle Ages. Now the results of the ALPS. The results for ALPS massive resections are basically the same as the one of my old series from the end of the last century. The merit of ALPS, however, was to change the strategy, was to open our eyes. Even if you resect everything, it's not good. It unveils unsurmountable biologic and oncologic burdens, and to allow us to change the game and to go for a final selection. The conclusion of resection is dismal. Basically, only overall 5 years, maximum 40%, which is difficult to be given a transplant. So shall we go back to transplantation? And here a series from the same period, 1995 to 2000, 25 transplantations. You can see even here massive type of surgery with ripples, other IVC resection, like we did with our liver resection. Results poorer, even poorer. Here is the intrahepatic ICC in dotted lines, which does a bit better than Perihaya, but then fails brutally at the long term. So not very good. And further, in more recent years, 18 transplantation for cholangiocarcinoma. Again, the same picture I told you to stick please in your mind. The 50%, we don't go much better than that if you look 57% with transplantation. Now, this gentleman, you know, Einstein says the only source of knowledge is experience. Anyone who has never made a mistake has never tried anything new. The question is if we are trying anything new, we are revamping something old. But we did. A revival season for transplantation in oncology, a lot of papers, you can see, and a steep increase in PubMed, and here from Massimo, HCC, NET, the metastases, and then 2017 Toronto with intrahepatic cholangiocarcinoma. The question again, if we are mad. This is the series from Toronto, it is important, because you can see that you reach a little better survival. This is the usual 50% bar. And if you are less than 2 centimeters, you can have reasonable transplantation results. And more series, you can see here, the Martin 2020, 69% survival. And very early, 65, again, the same series I showed you before. In summary, you can see that liver transplantation is coming, and we can say nowadays that safe indication In intrahepatic cholangiocarcinoma, less than 2 centimeters you can do. If you have more than 2 centimeters, then we have to speak. Basically, let's be honest, these are tumors that we mixed as hepatocellular carcinoma and we were transplanting. And nowadays you can transplant without any preoccupation for the long term. However, vascular invasion, intrahepatic metastasis, this is very important, intrahepatic metastasis, and of course intrahepatic disease are contraindication and they still remain. Now the food. If we apply transplantation, which is very expensive, and the experience of common sense would say for these advanced diseases, you cannot do it. And again, you risk to appear truly like a fool in front of the scientific community and in front also of the payers of the insurances. I know that you know this gentleman, Vishnu Gupta Kutilaya Chanakya is a hero in your country, and he's an interesting personality that I tried to learn by reading. The victory comes through superior knowledge and strategic deception. The truth is that the strategic deception is performed by the cholangiocarcinoma upon us until this moment. However, knowledge is power. Continuously seek knowledge, as it is the foundation of wisdom, growth, and effective decision making. And decision making is just what we need in this difficult disease. But further, I studied Sun Tzu. Sun Tzu is a Chinese general who writes, if you know neither the enemy nor yourself, you will succumb in every battle. And this is the beginning, Starzl and visionary. If you know yourself but not the enemy, for every victory gained, you will also suffer defeat. That's where we are today, where we have transplantation that is optimized, but the disease we don't know much. So back to cholangiocarcinoma, consider liver transplantation for lesions that are small, and there is some help. Remember my beginning when we classified the types of cholangiocarcinoma, and nowadays there are some genetic alteration, genetic signatures that are typical of the two types. Now the question is, shall we look at the types histology or shall we do the biopsy to see these changes? Because the changes are what are truly important. So biology is starting to come in head. And further, in transplantation there is a new player, more and more, in the center that I am now in Riyadh. We do 330 transplants per year. And a living donor is very important. However, a living donor should not be overused in indications that are not clear. And this is our very, very strong view, as you have even more responsibility to live donors than to deceased donors as a transplantation. Back to my friend Einstein, anyone who has never made a mistake has never tried anything new. And here we are. And we continue with the intrahepatic cholangiocarcinoma, the Martin, a good series, differentiating less than 2 and less than 5 centimeters. And Ito with a fantastic results, you can see here, by a very small number of patients. You can see that this is the use of neoadjuvant therapies. There are only 4 patients, of which, however, they are doing very well. And you can reach good results if you use neoadjuvant therapies. Now the question is, which neoadjuvant therapies? But what is the difference between the fool making mistakes and wasting organs and the genius? Everybody of you has a property, a house, and you know that in your city the location is more important than the size of your apartment or your house. But in oncologic transplantation, selection is not location, but selection will let you win. And selection must be done at any cost. So more than selection, you have strategy, the difference between the fool and the genius. And here is the last statement of Sun Tzu. If you know the enemy and know yourself, you need not to fear the results of 100 battles. So we need to know better our enemy, which is cholangiocarcinoma. I understand better what? The size, maybe not. The prognosis and the biology. Here, modern series. from 2020 in Guangzhou, China, a program that I know because I worked there and I transplanted patients there with blood donor. And you can see points given, look at the points. The more points you get if you have a number of nodules. So multinodular is very bad. The other points, the size, will remain at the size of 5. And thirdly, a high CA19-9 and the size of tumor. If you score the patients with more or less than 6, you can reach patients survival about 60%, but remember still the figures of 50% in the old series of resections. And further, the same group finds that a patient with markers of inflammation, it is something that is becoming more and more modern. We saw some good forwards at the European Surgical Association on inflammation and prognosis of transplantation. The results are also better than the ones we witnessed before. The way to go is to have randomized trials. These are 2 trials from Toronto. The trial from Oslo has been concluded by our friend Father Kline, and here is the paper. The paper is the Tesla trial. Tesla trial enrolled a very, let's say, small number of patients, quite frankly. It was well conducted. It used, like they do in colorectal metastases, prognostication by PET. However, the results I can show you here. They transplanted 5 patients out of the initial cohort, and only these are alive, but only 2 with recurrence. So the result of the study is, again, the result of the study is similar to the one of resections, as I showed you, 50%. The criticism of the study itself is that there were small numbers, high dropout, but it was a good point to have dropout, but they use conventional neoadjuvant therapy and non-immunotherapy. You can see here the usual GEMOX, irinotecan, only here 1 time insert, and in fact the patient is alive without recurrence. This series is very interesting. It comes from Mazzaferro, from the Tumor Institute of Milano. And you can see that it's a combination, of course, selection unresectable. They did GEM-CIS and TARE. TARE as a way to sterilize not only the liver, but also the small satellites. They went to transplant with lymphadenectomy and prior exploration. You can see a steep difference between transplanted patients. We don't know how Vincenzo gets it always so well. They have at 60 months 100% survival. And the others who did very poorly, like we know, with palliation for this disease. Why is that? Now, oncology for this disease has been not really helpful. These are the results of the ABC02 trial, gemcitabine and cisplatin, ridiculous. Just 3 months of survival gain. I will not undersign this chemotherapy myself. I don't put even the bar here. This is the study from Vale, more recent. Same, GEM-CIS, all the standard, horrible results. This is, of course, in palliative setting of carcinoma. We can say that systemic therapies have not been very helpful. Only now we start looking, as I showed you, for the differentiation of the mass-forming versus invading, FGFR2, NTKR, IDH1, and the genetic signatures. And immunotherapy is coming. Now, immunotherapy, we have durvalumab. Durvalumab, we heard yesterday from the nice colleague describing ACC. It's a PLD1 check immune inhibitor. It went through the TOPAZ trial, we will see. And the mechanism is to reverse the immune evasion by tumor cells. Basically, it strengthens the immunity of the host against the tumor. Now, these are the figures of the TOPAZ trial. Not brilliant, different but not brilliant again. And it is becoming a first-line standard of care in this disease. Now, the clinical standard is Gemcis and Durvalumab, and it seems to be effective. I believe we need to give some more time. The future directions are that we will use the biological markers, and we will use combination trials, not only with the chemotherapy, but also with the TARE and interventional radiation. However, we know that using immunotherapy, there is post-transplant rejection, and we are, yes, learning how to deal with it, since once you get the resection, the rejection is not quite easy to treat, and you may lose the organ. I put this nice slide, but frankly I am a surgeon, genomic spectra of cancer. The important message here is that we are starting to study this genomic spectra. And this is the way to go. I'm not an expert, and I'm only waiting for the advice of the experts, but this is the way to go forward nowadays. We know that there is a high mutational heterogeneity. This is very important, meaning you cannot follow only one gene saying, I have that gene, I am fine. Further, there is difference, however. It is the demonstration that if you have KRAS, the basis of FGFR, there is difference, like in the most common colorectal cancer. And the important point is that you can find in the vast array of genes that many are blockable by the immune therapy agents. Now, the study coming from Houston, from the Methodist Hospital, shows that you should not go for single genes, but you should go for cluster or gene pathway. And here are the results from Houston, which are quite remarkable. This is not statistically difficult, significant. The curve looks good, but the number is small, it's not. But if you look at the pathway, not at the gene only, the difference becomes statistically significant. So it looks like that for cholangiocarcinoma, we need, yes, local regional therapy, radiation therapy, systemic therapy, liver transplantation, but we need to look at the burden of disease, how much disease, and the biological selection. My conclusions are very simple. Clear indication for very early CC. So this is not anymore a secret, you can go. But if you don't have such a small tumor, then you need to consider investigational protocols and add the preparation of the patient, of the recipient, and also to look into some ethical board. That is important, particularly at the beginning of the disease, and to measure the response of the eventual neoadjuvant therapies you apply. The response for transplanting, like in every cancer in transplant, is imperative, and I will not transplant anybody without this. The biological activity and the stability are better determinants than the size. So basically time, the usual drug, that is not very expensive, time on the leads. And living donor remains for me the way to go. However, it puts on us surgeons an important burden and responsibility, not that we transplant patients just because we have the organ, and the willingness of the family to go ahead. Now, for the future, immunotherapy and TKI utilizations require further investigation, but we are on the right track. The important message for genetic signature is that the molecular subclass defines outcome, but we should look at the pathways, not at the single genes and the clusters. Now, CCA has a higher rotational signature than HCC, we looked at that, That's the reason why a single biopsy may not be the way. This is a difficult problem. We can do it in the discussion, and we need to incorporate